I'll be doing my presentation on principles of proximal femoral deformity correction. First, I'll go through some of the indications and the role of proximal femoral osteotomies, just a bit about the radiological assessment, the types of proximal femoral deformity, principles of deformity correction, discuss the osteotomy rules, and then I'll just go through a little bit about the specific considerations in varus osteotomy, valgus osteotomy, and greater trochanter overgrowth. And then finally, I'll just go briefly through the osteotomy technique using a blade plate, as I think this is one of the most common things we do at Western Health. So in terms of the role of proximal femoral osteotomies, they can be used to restore normal alignment, to increase the congruency and stability of the hip joint, to facilitate healing or remodeling of the femoral head and neck, to redirect the articular surface, or to improve the functional limb position in soft tissue contractures. These are some of the indications, so it could be a deformity such as coxa vara or valga, Perthes disease, a slipped capital femoral epiphysis, fracture malunion, a neuromuscular hip dysplasia, osteonecrosis, or in some cases femoral acetabular impingement. These are some key aspects of your radiological assessment when planning a deformity correction. I'll first go through the mechanical and anatomical axes. So the mechanical axis is a straight line connecting the center of the joint above and below. In the case of the femur, this is the center of the femoral head to the center of the tibial spines. On the other hand, the anatomical axis is the mid-diaphyseal line, and in the femur, this intersects the knee joint, generally about 1 centimeter medial to the joint center, and it usually passes through the piriformis fossa proximally. The angle between the mechanical and anatomical axis of the femur is about 7 degrees. And a key thing to note is that the anatomical axis can be curved, for example in the sagittal plane of the femur, whereas the mechanical axis always remains straight. These are two important angles that describe the joint orientation. The first one is the neck to shaft angle, and this is the angle between a line drawn down the center of the femoral neck and the anatomical axis of the femur. The normal value for this is about 130 degrees. The other angle is the mechanical lateral proximal femoral angle, and this is an angle between the mechanical axis of the femur and a line drawn between the proximal tip of the greater trochanter and the center of the femoral head. And this angle is normally 90 degrees. An important thing to note is that on your plain films, rotation will have an impact on these measurements. So when there's external rotation of the lower extremity, this will result in an increased valgus appearance to the proximal femur with an increased neck to shaft angle. This can be corrected by internally rotating the lower extremity. The neck to shaft angle is measured appropriately when the axis of the femoral neck is perpendicular to the X-ray beams. In terms of the axial angulation, this can be described as femoral torsion or version. There's significant variability in the numbers quoted for femoral anteversion. The numbers vary based on the technique used to calculate the femoral version. A paper by Strecker et al. Measured some normal femoral and tibial torsion angles in 500 bones, and they found that the anteversion was 24 degrees for the femur, whereas Fabry et al. Described normal femoral anteversion as about 30 to 40 degrees at birth, decreasing to about 8 to 14 degrees by adulthood. Key component of your preoperative assessment is the leg length discrepancy. This is best obtained from full-length standing AP radiographs, and it's the most valid and reliable method to measure leg lengths. The leg lengths can be measured from the center of the femoral head to the talus, or segmentally by measuring the length of the femur and tibia separately. Important thing to note is that deformities in the sagittal plane will not be appreciated. And the reason why this is all important is that when you perform your correctional osteotomy, it may alter leg length, so it's something important to consider. Another thing you can look at is the congruency of the hip joint. So this can be looked at by performing functional radiographs in adduction or abduction, And this then demonstrates what the congruency will be like post-osteotomy. The final radiological measurement I wanted to discuss is the articulotrochanteric distance. Now this is determined by drawing two lines that are perpendicular to the axis of the femur, one at the level of the tip of the greater trochanter and the other at the most proximal aspect of the femoral head. This is defined as a negative value if the tip is proximal to the articular surface. Now normally the tip of the GT sits at the level of the center of the femoral head. This measurement is important as it gives an indication of the tension that will be in the abductors. Moving on to the types of proximal femoral deformity, there can be congenital deformities, acquired, or those that are secondary to underlying skeletal dysplasia. Looking at a varus deformity, so in the case of a varus deformity, the tip of the GT will be proximal to the center of the femoral head. This leads to a decreased articulotrochanteric distance and it shortens the functional length of the abductors. This can then result in a Trendelenburg gait. In terms of your valgus deformities, the tip of the GT is distal to the center of the femoral head. This leads to an increased articulotrochanteric distance. The result of this is an increase in the functional length of the abductors, but a decreased moment arm, which increases the demand on the abductors. A valgus deformity is also associated with acetabular dysplasia due to the superior lateral joint forces in the acetabulum. In terms of your flexion extension deformities, this can be in the neck or the shaft. It's often compensated through lumbar spine and knee motion, but it can lead to gait inefficiencies and fatigue of the quadriceps. This can be seen in a SUFI or a fracture that can result in reduced range of motion or even femoral acetabular impingement. Now finally, there's deformities of anteversion and retroversion. As previously described, the normal anteversion is about 30 to 40 degrees at birth and then decreases with growth. If you have excessive anteversion or retroversion, it can affect the range of motion and gait. Excessive anteversion is also associated with a decreased functional length and lever arm of the abductors due to the relatively posterior and medial position of the GT. Now, moving on to the principles of deformity correction. This is quite a difficult concept. I'll go through what is called the CORA method. And the main first concept here is the center of rotation of angulation. So this is a point at the intersection between the proximal and distal axis lines. Now it's easier to understand in the tibia because both the mechanical and anatomical axes are the same, whereas there's 7 degrees difference in the femur. Once we have our CORA, we can then determine the bisector line. Now this is a line that divides the transverse angle into 2 equal parts. So in the case over here, we can see that the transverse angle is 164 degrees and it has been divided into 82 degrees and 82 degrees. Once we have our bisector line, then any point along this line can be considered a CORA. Next is the concept of the angulation correction axis. So this is the axis around which the correction is performed. This will make a bit more sense when I go through the osteotomy rules. And then finally we have the magnitude, and this is the angle between the proximal and distal axes, in this case 15 degrees. And this is the degree to which you would perform your closing or opening wedge osteotomies to correct the axis. So the first osteotomy rule is that realignment will occur without translation when the osteotomy and the ACA pass through any of the CORAs. So as you can see in this video, they're showing that the ACA is passing through the CORA along the bisector line. Rule number 2. If the ACA passes through the CORA, but the osteotomy does not, then the axis will realign with angulation and translation of the bone ends at the osteotomy site. So I'll just play that once more. So there's the bisector line and the ACA, which is at the CORA, but the osteotomy is performed distal, and this leads to angulation and translation. The final osteotomy rule is if the ACA does not pass through a CORA, the proximal and distal axes will be parallel but translated to each other. So our red and our blue line are parallel to each other but translated. So you can see again, translation between the two axes. So to give you an example, here we're looking at a femur with coxa. The mechanical lateral proximal femoral angle here is 113 degrees, which is 23 degrees more than the normal angle of 90 degrees. The core in this case is at the center of the femoral head, as well as the angulation correction axis. The osteotomy, however, is performed inferior to the CORA/ACA. So when we perform an opening wedge osteotomy of 23 degrees, you can see that this leads to angulation and translation of the bone ends at the osteotomy site, and this is according to osteotomy rule 2. Without actually translating the proximal femur medially, then the mechanical axis will be shifted laterally. So many people would argue that you need to translate the proximal femur medially, or translate the shaft laterally. In terms of a valgus deformity, the CORA is closer to the osteotomy, and therefore the degree of translation will be less. In this case, the femoral shaft will be shifted medially. Now comparing a closing wedge versus an opening wedge osteotomy. When you perform a closing wedge osteotomy, it requires removal of bone, and this leads to shortening of bone. The final length is equal to the concave cortex, so this cortex over here. In terms of an opening wedge osteotomy, you end up with a wedge-shaped bone defect, and the final length, on the other hand, will be equal to the convex cortex, so this length over here. So moving on to some specific considerations. So first I'll look at the varus deformity or a valgus osteotomy. As discussed earlier, the CORA is at the center of the femoral head. There would be relative lengthening of the adductors when performing a valgus osteotomy, and in some cases you may need to perform an adductor tenotomy in order to restore abduction. As mentioned earlier, the various osteotomies require medial translation. The osteotomy leads to lengthening of the femur as the neck becomes more vertical, and it's best performed distal to the lesser trochanter to lessen the tension on psoas. So just looking here what I mean by the tension on psoas. So in the first picture, in image 2 here, you can see that when the osteotomy is performed distal to the lesser trochanter, it decreases the tension on the psoas due to medialization and by bringing the insertion more proximal. If the osteotomy is performed proximal to the lesser trochanter, say in this case, it leads to increased tension on the psoas tendon. Now in terms of your valgus deformity and varus osteotomy, the core this time is at the level of the base of the GT. Your valgus osteotomies require lateral translation or medial translation of the shaft. It leads to shortening of the femur as the neck becomes more horizontal. And in this case, it's best performed proximal to the lesser trochanter, as in this case, it brings the psoas tendon insertion more medial and proximal. So just to demonstrate that, in image 2, you can see when the osteotomy is performed above the LT, there is laxity in the psoas. When it's performed below the LT, it increases the tension as the insertion is made more lateral and more distal. I thought I'd talk a bit more about varus osteotomies, as it's something that I've seen that we do quite commonly at Western Health. And this can be used in Perthes disease to maintain the sphericity of the femoral head and improve the congruency of the hip joint. Similarly, in developmental dysplasia and neuromuscular conditions such as cerebral palsy, it can also be used to improve the congruency of the hip. A derotational component can be added in order to change the femoral version or torsion. So looking at a technique using a blade plate, I'll just go through your preoperative planning. So the calculated angle is what will be used to insert the guide wire, and this is equal to the desired correction plus the angle of the plate. So for example, if the neck to shaft angle is 140 degrees and the desired neck to shaft angle is 115 degrees, then the correction angle is 25 degrees. If we're using a 90-degree blade plate, then the calculated angle is 90 plus 25 degrees, which is therefore 115 degrees. Then we would insert the guide wire at 115 degrees from the femoral shaft. So just in terms of the surgical technique, it's a standard lateral subvastus approach to the femur. The entry point is just below the trochanteric physis. The guide wire is inserted at the calculated angle, and it's inserted at the center of the femoral neck on the lateral view and in the inferior half of the femoral neck on the AP view. The blade plate chisel is then inserted, and then if performing a rotational component, you can insert derotation pins proximal and distal to the osteotomy site. You then perform an oblique osteotomy that is parallel to the blade of the chisel. You then insert the blade plate into the track created by the chisel, and the plate is reduced to the shaft. This will then result in your correction angle. So as previously discussed, it would be 25 degrees. And by doing so, the femoral shaft is medialized with the plate. Finally, I just wanted to talk about the greater trochanter. So the greater trochanter apophyseal plate and the femoral head physis functionally act as one. You can get eccentric physeal arrest that can occur due to infection, trauma, or vascular damage, and this can result to sparing of the femoral head physis and greater trochanter overgrowth. This can then mean that an intratrochanteric or a subtrochanteric osteotomy alone may not actually restore the normal neck to shaft angle and MPFA. And in some cases, you may actually need to perform a trochanteric transfer in order to fix both of these. Some final thoughts. In terms of the hardware, it's recommended to remove the metal in order to facilitate future hip surgery and to reduce the risk of stress rises and fracture. So in summary, preoperative planning is essential for proximal femoral deformity correction. Important things to consider is the congruency of the hip, the soft tissue tension, and the leg length. And in some cases, you may not be able to restore the congruency of the hip with a proximal femoral osteotomy alone, and in some cases you may actually need to consider an acetabular osteotomy, but unfortunately this was beyond the scope of this talk. Here are my references, and thank you for your attention.